Okay, so here's part 2 to our peripheral arterial lecture. We are specifically going to talk about aneurysms. It's fairly straightforward. Normally, our vasculature is under constant pressure. Once you have changes to the shape of that vasculature, especially weakening of that vasculature, you're at an increased risk for ruptures. So we have a few different types of aneurysms. Obviously, if the one on the left is a AAA, if you have a AAA and it ruptures, there's a high likelihood that you will not survive, especially if you're not already in the hospital. Most aneurysms are found on some sort of benign diagnostic thing. So you go out for a KUB because you're having issues, and oh, by the way, we've noticed that your abdominal aortic aneurysm is getting bigger than it should be. Typically, what's going to happen is that we'll want you to be on a blood pressure medication because we don't want you to be under high pressures, because the higher the pressure, the more likely that aneurysm is to rupture. So that's a very big, important takeaway. And then as a nurse, if you are taking care of a client with an aneurysm, that you are able to recognize signs and symptoms of a rupture. So we'll talk about the different kinds and what it means. So an aneurysm itself is a weakness in a section of a dilated artery. It causes it to balloon. It's like we talked about, if you inflate a balloon over and over and over and over, you put it under constant pressure, it becomes weaker and thinner, stretched out. That's what happens to your vasculature. And because of that continued pressure, your blood pressure, probably hypertensive blood pressure, you are at increased risk for it rupturing and you bleeding out. So something called a aortic dissection. So where the aorta is, so that area around there is what we're going to look at. So you have this kind of tearing of the lining of the artery. So instead of it just ripping or blowing out, what's going to happen is that usually I think it's the tunica intima and the tunica media kind of separate, and blood starts to leak in between those spaces. And you're still going to lose cardiac output, but it's going to be like more insidious. So we'll look at an aortic dissection too. So here we talked about the different types. So here we can see a thoracic aortic aneurysm, and that's down here. We see up top, this is our aorta coming out. So this is a TAA. You have a AAA. Usually notice the location is distal to your kidneys. So one of the things for this that we kind of have to do is we clamp off these arteries as we're repairing this section of your aneurysm, your abdominal aortic aneurysm. So that can increase the risk for damage to the kidneys because we're clamping off blood flow, because you don't want blood running here if you're trying to replace it. They do have also iliac aneurysms. Never really had a client come to me in my work experience with an iliac aneurysm. Doesn't mean they don't have triple one that we see in our patient population. As with most things cardiovascular, aneurysms are often asymptomatic. So again, it can be very hard if you're somebody that does not come in and does not present with the typical signs and symptoms that we're going to talk about, for them to even know that you have an aneurysm. Our health promotion and maintenance, you guys, it's the same. Diet, exercise, healthy lifestyle, control your blood pressure, i.e. take your meds as prescribed, and make sure that you are doing things to not have ruptures, not have changes in your blood pressure to promote rupture. So here we kind of see the image, the illustration here, where we see the ballooning because of the blood flow and the high pressure. and then you have that bursting of that aneurysm. So our clients will complain of a constant pain, a gnawing, I know it's a weird word, a gnawing feeling, something's not right in their abdomen. If they complain of flank or back pain, that generally means that you've had a rupture. They may present with this pulsating abdominal mass. Don't go palpating on it because you're going to rupture it. You don't need to listen to it right on top of it. Go a little bit above, a little bit below. You're still probably going to be able to hear a bruit. You might even be able to feel a thrill. We're not pressing on it. You're just touching. And then usually we know that that client probably already has elevated blood pressure. Unless we're talking about a client who is in cardiac tamponade, which we're going to talk about cardiac tamponade. And obviously their blood pressures are going to drop if you are losing blood either in cardiac tamponade or rupture of an aneurysm. So for a TAA, severe back pain, which is the most common, but you can also have this hoarseness, chronic coughness, shortness of breath, difficulty swallowing. Think about the location of the TAA. So this is right off your heart, so it's right by your esophagus, and now you have more pressure there. And here you can see what happens. We've gone from normal to this outpoaching, and now this surgery to repair that. Obviously, and again, I'm just going to say it again, that for these questions, urine output is the most missed topic because we don't understand that if you have decreased perfusion to your vasculature, you're going to have decreased perfusion to your kidneys. Especially if you have a rupture, because you're in hypovolemic shock if it ruptures. Sorry, the computer is slow here. So here, kind of the illustration, you see the changes in the structure of the vascular right beneath the kidneys. It's kind of this outpoaching area right through here. Usually, if we do catch it in time, they're going to be in hypovolemic shock. You know, compensatory mechanisms are going to be in effect. So we have tachycardia and hypotension, cool, clammy skin, decreased urine output, changes in LOC. We want to be able to decrease that client's blood pressure just like we would with hypertensive crisis. Here we're going to say we want to get that systolic between 100 and 120. So we want them a little soft, if possible. It's not really soft. It should be normal, but it's probably not normal for them. Long term, we want to maintain that blood pressure between 130s and 140s if they are hypertensive. So lots of teaching about your antihypertensive medications and lots of teaching about your smoking cessation, the same stuff that we always talk about. So here we kind of see the process again of what you're looking at with this outbulging, and we see it explode on us. We know that we're thinking abdominal pain, back pain, abdominal masses. They have other underlying comorbidities, hypertension. Usually they have hyperlipidemia. We know if they rupture, they're at increased risk for shock. Look for things that are going to tell us that they're having changes in LOC, because once it ruptures, they're not going to be like, oh, I think it ruptured. They're going to have a loss of blood flow. Okay. Things that can be done for the client, we can go in and we can repair. So basically we're going to go in between. We'll cut this area open and put in what is essentially like a Kevlar material, because it's going to be under high pressure. It needs to be fairly strong. And then we'll sew the vasculature back around that resection piece. Usually we only do that once the size has gotten bigger than 5.5 centimeters. The doctors are going to tell you, hey, you know, it's this big, we need to continue to monitor you, or it's this big, we need to do surgery emergently. Obviously, they're going to send you to surgery if it's starting to rupture. We talked about hypotension. We've talked about hypovolemic shock. You can end up with ischemia, which is going to cause an MI. You're going to have acute kidney injury. You can end up in respiratory distress, paralytic ileus, all the nasty stuff that we've always talked about with cardiovascular disorders. So our priority interventions are to watch their blood pressure, make sure that we're monitoring for evidence of graft occlusion or rupture post-operatively. Again, we want to keep them that 100, 120 level, so we know prolonged hypertension needs to be assessed, but you're still going to make that decision based upon whatever the healthcare provider says for their mean arterial pressure. You're going to do frequent vital signs, frequent distal pulses. The only thing that really changes here is that you want to make sure that you are not putting pressure on that graft, so you want to maintain that head of the bed below 45 degrees. Don't really care that you understand the difference between the types of an aneurysm. So here, this fusiform, it goes all the way around. This pseudoaneurysm is this small little pouch-like versus a saccular, which is much bigger. A dissecting. Now, this is what we talked about when we said we have these layers. Forgive my drawing. So this is the outside layer of the vasculature, tunica, intima media. So these layers that should be together start separating apart. And instead of blood flowing into the vasculature, they're flowing into these new separated areas. So they're filling up like that. You're going to lose cardiac output. All that blood is going into the layers between your vasculature and not participating in cardiac output anymore. So that's a dissecting aneurysm. And then obviously the last one is the absolute rupture. We want to get their blood pressure up, give them fluids. We want to monitor their kidney status, check their I's and O's. We've talked about 30 milliliters. Look for weight gain, because where's the fluid going? Check for BUN, check their creatinine. If they're in the ICU, which I would probably assume, you can even look at the CVP and the pulmonary artery wedge pressures. Listen to the lung sounds, because fluid has to go somewhere, and it's usually going to go to areas where it's not, and it loves the alveoli. And then still do your assessments for pain. So here we see the processes of what we've gone in, and we have done surgery for these clients to allow normal blood flow in both of our AAA and our TTA, excuse me. So here's kind of, again, a picture of what we talked about with a normal aorta and an aortic dissection. So instead of that blood participating in cardiac output, it's leaking into the spaces. So this is often associated with genetics, Marfan syndrome. I don't expect you to know that. It's genetics. They're going to have activation of the sympathetic nervous system, because basically they're going into shock. They're going to have a decrease in their pulses. They're going to have changes in LOC, signs and symptoms of shock. And of course, obviously, oliguria. They may complain of a sudden tearing, ripping, or stabbing abdominal or back pain. And obviously, hypovolemic shock again. That's the big one, because blood is no longer participating in cardiac output. That's very strange, and I apologize, but I don't know why it's looking like that. What we want to look for, we know that a rupture, a dissection is a medical emergency. It's going to be massive hemorrhaging, shock, and death. You have to get them to surgery immediately, so you have to recognize signs and symptoms very early on. Because you do have issues with blood pooling and coagulating, you can end up with that thrombus. And all of this decreased perfusion is going to lead to something called MODS. Nothing on the test about MODS. I don't think it'll be on the NCLEX, but I want you to know, just if you hear it again, it's multi-organ dysfunction syndrome. We want to assess their circulation, distal extremities, pulses, color, temperature, urine output. All the same old sames. One of the big complications is cardiac tamponade. Cardiac tamponade is very bad. So when we talked about our pericardial sac, we said it should have a little bit of fluid in there. And in this illustration, I can see that there is a lot of fluid in there. There's only so much room, right? So if a normal is like maybe 10 to 20 milliliters of fluid in the pericardial sac, just to provide lubrication, right? Protect you from your lungs. Now we have this lot of fluid accumulation, and it's going to put pressure on your heart. So it's going to put pressure on your heart. Your heart's not going to pump effectively. So you're going to end up with signs and symptoms of decreased cardiac output. The biggest one that we always talk about are our 5 Ds here. Decreased blood pressure, decreased pulse pressures, narrowed pulse pressures, distended neck veins, distant heart sounds. So they may say distant, they may say muffled, they may say diminished. If you see any of those words on anything NCLEX or test, they are talking, or I am talking about cardiac tamponade. And then you end up with this thing called a different pulse, pulsus paradoxus. We talked about having an irregular rhythm with AFib. You can also have this pulsus paradoxus with cardiac tamponade. And that is the end. So, again, I think for my exam specifically, there's something like, I want to say 9 to 13 questions about PAD, PVD. So, between those two different topics, keep it simple, keep it to the point. You want to monitor their cardiac output, check for those sudden acute signs and symptoms, make sure you're checking blood pressures, controlling blood pressures, make sure that you're looking at eyes and nose. That is the end of PAD. If you have any questions, let me know.